Okay, my topic today is SGLT2 inhibitors in the prevention and treatment of heart failure. Probably the most important result of the rosiglitazone fiasco or the rosiglitazone controversy in 2008 was a directive given by the FDA to pharma companies involved in diabetes research, that from 2008, any drug that is marketed as an oral hypoglycemic agent should also prove that they not only reduce glucose, of course, that is an essential thing, but that they also are not associated with clinically meaningful increases in the rates of major adverse cardiovascular events, which means they have to prove that these drugs are cardiovascular safe. But if left to me, I would say that it is not enough. Actually, these drugs should also prove that they are not only safe, but they are beneficial. They are associated with a clinically meaningful decreases in the rates of major adverse cardiovascular events. Well, that has not so far happened. So what happened after this post-rosiglitazone fiasco is what you can see in the charts. The number of cardiovascular outcome trials, which is the black screens, has gone up multifold. And number of people enrolled in the cardiovascular outcome trials of diabetic drugs, which is the gray square, that also you can see has increasing year by year. And so when SGLT2 inhibitors came into the scene, they also have to conduct trials to show that they are safe as far as cardiovascular outcomes are concerned. So naturally, the primary endpoint of these cardiovascular outcome trials was MACE, which is cardiovascular death, non-fatal MI, and non-fatal stroke. But at the end of the day, everyone, including the sponsors, were surprised to know that the benefits in heart failure was much, much more than expected. In fact, nobody has expected benefits in heart failure with an SGLT2 inhibitor. So what I am going to do today in the next 13 minutes that I have is to talk about where we stand as far as SGLT2 inhibitors are concerned with respect to prevention of heart failure in diabetes, prevention of heart failure in non-diabetes, treatment of heart failure in diabetes, treatment of heart failure in non-diabetics, and finally heart failure with preserved ejection fraction in diabetics and non-diabetics. Now, before going further, why should we try a drug like SGLT2 inhibitor, which is an anti-diabetic drug, in the treatment of heart failure patients without diabetes? That is a question that first I have to answer. Number one, patients with heart failure have similar pathophysiological features as patients with diabetes. There is no difference as far as the pathophysiology of heart failure is concerned in those with diabetes versus those without diabetes. Two, we really do not know what are the mechanisms by which SGLT2 inhibitors help in heart failure. But whatever little we know, that is the factors that help in prevention and treatment of heart failure, glucosuria, natriuresis, metabolic effects of SGLT2 inhibitors, they are all seen in patients with diabetes as well as without diabetes. And finally, the cardiovascular benefits, the heart failure benefits in all trials that have so far been done with SGLT2 inhibitors has nothing to do with blood sugar control. It is absolutely out of the blood sugar control purview. So with this background, this is a mechanistic rationale to investigate the cardiovascular outcomes, especially the heart failure outcomes of SGLT2 inhibitors beyond type 2 diabetes mellitus. So let me start with prevention of heart failure in diabetes. The first trial, as we know, is EMPA outcome trial with empagliflozin. And as I already said, this was basically a safety study to prove that cardiovascular outcomes are safe with empagliflozin. So 7,000 patients with diabetes and CVD, empagliflozin versus placebo. And you can see that the primary endpoint, there is no heart failure because obviously it was not expected. And even the secondary endpoint, there was no heart failure. And then you can see the results. The primary composite endpoint is just borderline significance, P is 0.04. Secondary composite endpoint, trend 0.08. That is all, nothing very fascinating or exciting about it. But now comes the surprising thing. Death from cardiovascular cause and cardiovascular death, you can see was significantly better in the empagliflozin group. Now, even more attractive is the hospitalization for heart failure. Hospitalization for heart failure or CV death, both of them significantly better in the empagliflozin group. Whereas look at myocardial infarction, there is no difference. Myocardial infarction has not been reduced by the empagliflozin group. So, of course, now we know that it is not only safe, but it actually prevents heart failure. And then came the canagliflozin trial, which is the CANVAS trial. While the empagliflozin was a purely secondary prevention trial, which means all the patients had atherosclerotic cardiovascular disease. CANVAS had not only patients with atherosclerotic cardiovascular disease, but also patients without atherosclerotic cardiovascular disease, but having risk factors like diabetes of long duration, blood pressure, smoking, albuminuria, HDL, etc. The results were almost same. As far as the primary endpoint was concerned, it was just borderline significant or maybe not significant at all. But when you come to heart failure, you can see the significant 30% reduction in canagliflozin as well as hospitalization for heart failure is concerned. Now, by the time the DECLARE trial was going on, we already knew that there were benefits in heart failure. So the researchers, the investigators of the DECLARE TB58 added a co-primary endpoint of heart failure also, because now we know that these gliflozins have benefit in heart failure. So this contained more of primary prevention, 60% people with multiple risk factors and only 40% with established ASCVD. And as I said, this was the first study to use heart failure as a co-primary efficacy outcome, atherosclerosis and heart failure. And they also looked at MACE, but it was a co-primary endpoint of MACE or composite of heart failure associated hospitalization and cardiovascular death. And they found that dapagliflozin did reduce cardiovascular death in heart failure. It doesn't matter whether it's primary prevention or secondary prevention. It doesn't matter whether the patient has atherosclerotic cardiovascular disease or not. But MACE was not significantly reduced in those who did not have atherosclerotic cardiovascular disease. Patients without atherosclerotic cardiovascular disease had no benefit as far as cardiovascular death, non-fatal MI or non-fatal stroke was concerned. But reduction in cardiovascular death and heart failure was there, irrespective of whether the patient had established atherosclerosis or not. And as already said, the cardiorenal benefits were unrelated to the level of glycemia. And it was not explained by traditional risk factors like blood pressure or body weight. So if you look at the initial SGLT2 inhibitors trial, cardiovascular outcome trials, we have EMPA-REG, which is 100% secondary prevention, CANVAS with 34% primary prevention and 66% secondary prevention, and DECLARE with 60% primary prevention and 40% secondary prevention. Of course, the secondary prevention include not only coronary artery disease, but also cerebrovascular disease and peripheral vascular disease. And the primary prevention were those patients without established coronary artery disease, established atherosclerotic disease, but having multiple risk factor trials. So these three trials told us that SGLT2 inhibitors consistently reduce the risk of heart failure hospitalization to a similar magnitude. All three drugs were the same across the spectrum of baseline atherosclerotic risk, whether you have coronary artery disease or cerebrovascular disease of none of these things, it still benefited. Across the spectrum of heart failure, whether you have heart failure or no heart failure, it did not matter. But these trials did not tell you about the treatment of heart failure, because only a minority of patients had heart failure, only about 10 to 14% had heart failure. And because heart failure was not a primary endpoint, data capture with related to key heart failure related elements were incomplete. So this does not tell you about treatment of heart failure. So SGLT2 inhibitors do prevent heart failure in type 2 diabetes mellitus. We have sufficient data as of now, whereas we don't have data as far as non-diabetic is concerned. Whether they prevent heart failure in non-diabetics, we have no data so far. Okay, now let's come to treatment of heart failure in diabetes and non-diabetics. Well, this is again the first 4 trials. As I said, even though the numbers were less, only 10 to 14% were baseline heart failure, there was no difference as far as CV death or heart failure hospitalization was concerned. In patients with history of heart failure, there was benefit. In patients without history of heart failure, also there was equivalent benefits. And so was the DAPA heart failure trial designed, which looked at the benefits of dapagliflozin in heart failure with reduced ejection fraction. It included diabetics and non-diabetics. In fact, the majority were non-diabetics. symptomatic heart failure, ejection fraction less than 40%, raised pro-BNP, and the exclusion criteria were an eGFR of less than 30, remember that, and symptomatic hypotension or a systolic BP of less than 95 millimeter. The primary endpoint was purely heart failure related, worsening heart failure or cardiovascular death. And at the end of the study, it was shown that dapagliflozin reduces cardiovascular death, worsening heart failure, and overall death when used on top of optimal medical therapy in heart failure due to reduced ejection fraction, irrespective of baseline diabetic status. It was a well-treated population, remember, 90% were on beta blockers and RAS blockers, and 70% were on mineralocorticoid receptor antagonists, and there was a significant reduction in the primary endpoint, irrespective of the presence of diabetes. There was only a small group on ARNI, 11%, but benefits could be demonstrated in that group of patients also. Even all-cause death, you can see, was reduced by 17% with a significant p-value of 0.022. And there was no significant difference, fortunately, as far as adverse events are concerned. So you can see the primary composite outcome, 26% reduction in cardiovascular death bar heart failure with dapagliflozin. It doesn't matter whether you have diabetes or no diabetes, the curves are well on the left of the central line. And if you divide patients according to HbA1c, less than 5.6, 5.7 to 5.9, and more than 6, no difference whatsoever. You look at various individual endpoints, with diabetes, without diabetes, no difference at all. And so one sparrow does not make a summer, you need more trials, and so came the Emperor reduced trial with empagliflozin 10 milligram versus placebo, almost similar primary endpoints, first event of cardiovascular death or heart failure, and they also included GFR as a secondary endpoint. The results are almost same. You can see significant reduction with empagliflozin in the primary outcome, significant reduction in the first and recurrent hospitalization for heart failure, again with empagliflozin. And surprisingly, or maybe even more excited result was there with respect to GFR. The red you can see is empagliflozin. There was a sudden reduction in GFR with empagliflozin as expected, but then you can see at the end of 5 years, the curves cross each other, and the patients who were on empagliflozin had a higher GFR compared to those who were on placebo, which means that there was a significant reduction in the progression of renal disease also. And since being heart and kidney being so closely related, it is not surprising that this benefit in renal endpoints can also be translated into benefits in heart failure mediated events also. So the Emperor reduced trial, if you compare with DAPA heart failure, the Emperor reduced trial had more sick patients. They had a lower ejection fraction. The mean ejection fraction was 27% compared to 31%. They had higher concentration of natriuretic peptides. They had a lower eGFR. The cutoff point was 20 ml in empagliflozin trial versus 30 ml in Emperor reduced trial. Remember that as the GFR comes down, the hypoglycemic effect or the benefits on reduction of blood sugar comes down and even disappears in patients with these drugs. But the benefits on heart and kidney becomes more and more as the GFR comes down. So now we have data that you can use it even up to an eGFR of 20 ml per square meter. And it is more likely 20% of patients in EMPA heart failure, Emperor reduced were on ARNI compared to 11% patients in the DAPA heart failure study. So now we have data that even on patients with ARNI, there is benefit with the SGLT2 inhibitors. But of course, with all this, we know heart failure with reduced ejection fraction is still not a good disease. Despite all we have, despite ARNI, beta blocker, MRA, the mortality rate at the end of 5 years is nearing 75%. So we do require more weapons in our therapeutic armamentarium, and SGLT2 inhibitors is definitely one welcome addition to that. But the disappointing story is respect to heart failure with preserved ejection fraction. We still have no treatment options identified. We still have no drugs that will reduce the mortality in patients with heart failure with preserved ejection fraction. So to conclude heart failure with and SGLT2 inhibitors, what I have, the initial questions that I have asked, prevention of heart failure in diabetes, yes, we have strong data now that in diabetes, heart failure can be prevented with an SGLT2 inhibitor. Prevention of heart failure in non-diabetics, we still do not have any data because all the three trials, primary trials, were in diabetics. Prevention of heart failure in diabetes, yes, we have data. Prevention of heart failure in non-diabetics, yes, we have data. Both the trials had more patients, non-diabetic patients, than diabetic patients. And finally, heart failure with preserved ejection fraction, whether it is diabetics or non-diabetics, we still have no data. And if you ask my personal opinion, I don't think this will be useful in preserved ejection fraction because none of the other drugs, ACE, ARBs, mineralocorticoid receptor antagonists, or beta blockers, have shown any benefit in heart failure with preserved ejection fraction. So possibly we'll have to keep our fingers crossed till more data. Thank you very much for this opportunity.